Okay, yes, I'll start. Thank you for invitations. My name is Dong Hwa Heo. I'm a neurosurgeon in South Korea. Now I work in the Endoscopic Spine Surgery Center in Seoul Bumin Hospital in South Korea. Today's my topic is contralateral sublaminar approach using the biportal endoscopic approach for the lumbar pathologic regions. The advantages of the contralateral approach is first is the better view of the existing root and foramen, and the better views we can see it clearly, see the medial border of the pedicle, and we can reduce the bone work during the interlaminar approach, and we can minimize the facet joint injury during the posterior endoscopy approaches. So the indication of the contralateral sublaminar approach using the biportal endoscopic approach, UBE. The first is the foraminal stenosis and HMP and migrated disc herniations, and especially the better work in the upper lumbar lesions. And also we can remove juxtafacet cyst using the contralateral sublaminar approaches. So today's my presentations focused on the surgical technique of the biportal endoscopic sublaminar approaches. So just with tilting the endoscope, we can easily see the contralateral approach without any maneuvering. So just these 2 points is a lutein, the skin incision points of the lutein UBE. So however, the target, if we main target the external lutein and upper foramen, we have to modify the two skin incision more caudally. And if main target is the traversing of lutein and lower foramen, we have to make the two skin incision points more the cranially like this. So the incision area modification is very important for the easily approach for the foramen contralateral. So I firstly see the base technique. So the main target is the contralateral traversing the root, and you can see this is the contralateral ligament flavum. I firstly divide the superficial and deep layer. And firstly, I remove the superficial layer of the ligament flavum. Now I drilled at the lower lumbar lamina and upper portion. So you can see the border, the lower border, and we can easily detach the ligament flavum from the lower lamina upper portion. And we did a small laminotomy. We can clearly detach contralateral ligament flavum. Dissect the area of medial border of the SAP. You can see the complete dissections of the contralateral ligament flavum. We can easily and safely remove of the contralateral ligament flavum. You can see the contralateral traversing of root, and you can see the medial border of the pedicle. The final view, this is the base technique. And the second is the contralateral external root decompression. So this is the superior articular process of a tip. This is the foraminal ligament, lateral sleeve of the ligament flavum. The SAP tip is the main landmark of the contralateral approach. Firstly, I partially remove the tip of the contralateral SAP, and you can see the contralateral foraminal ligament. We can easily detach and dissect and remove the foraminal ligament easily without any injury of the neural structures, and the removal of the hypertrophied foraminal ligament slowly and carefully. And you can see the external lobe contralateral. You can see the contralateral lobe root. So dissections more laterally, and you can see the foraminal ligament, and this portion is the contralateral external lobe root. So I'll remove more laterally foraminal ligament we can safely decompress and expose of the contralateral extending lobule. This portion is the disc space. The main, the surgical landmark is the contralateral SAP tip and foraminal ligament. Now I palpate the medial board of the pedicle like this. So this is the basic technique. And now I show the clinical cases. First case is the foraminal disc herniations. We can easily remove the foraminal disc herniation using the contralateral UBE approach. Firstly, we expose the extending lobule and dissected and the removal of the ruptured disc and final view. Now I show the video. So we firstly did ipsilateral laminar dissection and ipsilateral midline laminotomy using diamond drills. I prepare the NSK drill, and you can now I midline laminotomy, right to left approach, and you can see the middle portion of the ligament flavum. This is a contralateral ligament flavum. Now I remove of the contralateral ligament flavum, left side. Partially remove of the contralateral ligament flavum and foraminal ligament. You can see the extending lobule here. So I more laterally, more superiorly remove of the ligament flavum, and you can see the contralateral. This is the superior articular process. Now I remove the foraminal ligament. Now you can clearly see the foramen and the extending lobule, maybe ganglion here, and you can see the unmigrated foraminal disc herniations. So I dissected here and remove here. We can easily and safely remove disc herniation without any injury of the neural structure, and also we can decompress the contralateral foramen and extending lobule here. So it's a final view. If we use the biportal endoscopic surgery, we can very safely surgery, very magnified clear view, endoscope view. So yes, final view. You can see the contralateral lobe root and medial board of the pedicle. So I move to the next cases. So now I show. So this patient, the left side, foraminal disc herniations, you can see. So now I did the contralateral laminar approach. First laminar dissections here, and that I did a midline laminotomy using the diamond drill. Just very narrow laminotomy. Contralateral sublaminar bony decompression. And now I remove the contralateral ligament flavum and mid portion of the ligament flavum. Now I partially remove of the contralateral ligament flavum, and you can see the severe adhesion with the disc herniations, and you can see the disc herniation particle under the extending lobule. Now I dissected the disc herniations below the extending lobule, and now I remove of the ruptured disc herniation firstly, and also you can see the next large size of the foraminal disc herniation, and you can see the extending lobule S3, yes, the final view. So, and the second case is a male patient complained of the epidermal term pain. You can see the unmigrated disc herniations at the L23 area. So you can see the foraminal disc herniations as well as central stenosis. So my decision is sublaminar contralateral approach. Now I firstly did the medial laminotomy. This procedure, very familiar procedure. If we do the unilateral laminotomy, bilateral decompressions using one portal or biportal, this approach is very familiar approach. So now I did the extended upper portion of the laminotomy and contralateral ligament flabum removal. Also, you can see the rupture disc herniations. The herniated disc particle adhere with the external tooth. So I firstly dissect, and you can see the disc herniation particles here. This approach is very familiar approach. If we treated the spinal stenosis, we frequently did this approaches, just modification of the contralateral approach. Now I remove of the foraminal disc herniations firstly, and the external root was completely decompressed here. And also, this patient also have the central stenosis. Also, I did the decompression, external root as well as the traversing root, like here. The final view, I did the two root decompression using the contralateral approach, L2 root as well as L3 root. So after surgery, you can see the complete removal of the foraminal disc herniations as well as the resolve of the central stenosis after surgery. So I showed another cases. This patient down migrated disc herniation at high upper lumbar area. I did the sublaminar contralateral approaches. So right to left approaches. So I did the midline laminotomy, left to right side midline laminotomy here. This procedure is very familiar approach when the endoscopic decompression of the spinal stenosis. So this is the mid portions. Now I remove of the contralateral ligament flabum here, and you can see the contralateral S3 lobe, and you can see the rupture disc herniations, and you can see the S3 lobe, and also I remove another particles, second particle, remove of the foraminal disc herniation, down migrated. Also, you can see the medial border of the S3 particles, and also I remove of the rupture disc particle again. Also, I explore and dissected under the contralateral S3 lobe root, and also remove another disc herniation. Also, you can see the lamina2 disc particles. Big particle was also removed. The fragmented, yes. Also, you can see the S3 lobe root and the medial border of the pedicle. The complete decompression of the contralateral S3 lobe root, and I can completely remove the foraminal disc herniations down migrated. So foraminal stenosis is another good option for the contralateral sublaminar approach. You can see the central stenosis as well as foraminal stenosis. So you can see the foraminal stenosis as well as severe central stenosis. So my decision is the 3 root 2 decompressions. Many surgeons recently frequently done the unilateral laminatory bilateral decompressions using the biportal or the uniportal. So firstly, I did the right side L5 lobes to decompression. I did the lateral recess decompression firstly. So now I removed the right side hypertrophied ligament flabum first, and lateral recess decompression first. And you can see the L5 lobe, and I did the contralateral ligament flabum. And now I remove of the remnant, the contralateral ligament flabum and bony decompressions. So this procedure is very familiar to the endoscopic spine surgeon for the treatment of the central stenosis, and I did the more cranial decompression for the external lobute. You can see the L4 external lobute here. And this portion is the tip of the SAP. SAP tip is very important landmark. And also I remove the tip of the SAP and the contralateral foraminal ligament. And now I decompress more laterally. L5 lute, L4 knob lute, left side, decompressed. L4, L5 knob lute, left side. And finally, you can see the right side L5 knob. I did the triple lute decompression using the biportal endoscopic surgery. Left side L5, right side L5, left side L4 knob lute decompression using single approach. So after surgery, the foraminal stenosis and central stenosis were resolved after biportal endoscopic surgery. Also, the cestal view, also you can see the decompression of the foramen after surgery. So this patient has the age of very old. Her condition is very poor due to ischemic heart disease. You can see the severe foraminal stenosis and central stenosis. So maybe this patient is the indication of the fusion, such as the tulip or olive. So, however, these patients cannot receive the fusion surgery due to poor medical illness history. So my decision is bilateral contralateral approaches for the 4-root decompression. So firstly, the left to right side approach. So this is contralateral ligament flavum hypertrophied. So dissection. This approach is recently very similar approach for the endoscopic spine surgeon. So I did a small laminotomy using the drill. Yes, L5 upper portions lamina. So I remove of the hypertrophied contralateral ligament flavum firstly. Dissection between the plane, the dura, and the ligament flavum. And you can see the L4 external lobute, and you can see also the rupture disc herniations here. So I did a dissection of the foraminal disc herniation from the external lobute, and I carefully remove of the foraminal disc herniations and adhesion tissue firstly. So the rupture disc herniations severely adhere to the L4 external lobute. I can the foraminal disc herniation without any injury of the external lobute. So I did the decompression, the right side L5, L4 root 2, and L5 knob here. So firstly, I did the 2 root decompression. I moved to the contralateral side. The same procedure was performed using this approach. We can minimize. You can see the severe adhesion, the dura between the ligament flavum. So I removed the hypertrophied ligament flavum. Firstly, I decompressed the contralateral L5 lobute here. You can see the L5 lobute here. And then move to the more cranially for the external lobute decompressions here. So I now remove the foraminal ligament, the lateral sleeve of the ligament flavum here. So dissections very carefully. So firstly, careful dissections between the ligament and the dura. You can see the foramen L4 lobute here. So we have to remove more cranially for the complete decompression of the contralateral external lobute. So you can find a view L4 lobute here, L4 lobute here, L5 lobute. I did it 4 root decompressions using the bilateral contralateral approach. Comparing the preoperative MRI, you can see the complete decompression of the central canal as well as foramen. So after surgery, you can see the foraminal decompression as well as the central stenosis. The final case is the juxtasphasis cyst removal, such as the ligament flavum cyst or synovial cyst. This man complained of the right leg pain. You can see the foramen synovial cyst of the L5. The contralateral approach very useful for the removal of the synovial cyst. You can see the synovial cyst, the normal dura. After operations, we can completely remove the contralateral synovial cyst. And now I show my video. So this patient complained of the right leg pain. You can see the calcified synovial cyst. So my decision is the contralateral approach. So the calcified synovial cyst severely adhere with the dura. Firstly, dissection is first. We have to find the surgical dissection between the synovial cyst and the dura. Now I remove the calcified synovial cyst. The calcified mucinous components was the drainage out. This approach is very familiar approach for the biportal endoscopic surgeon as well as the PSLD surgeons. You can see the traversing of root. After dissection is first, removal of the cyst is next. So I did now the remnant cyst wall using the endoscopy equipment. So you can see the very severe adhesion. Cyst with the contralateral traversing of root. Dissection first and removal is next. We can completely remove the cyst lesion without any injury of the dura and nerve roots. The final view of the biportal endoscopy removal of the synovial cyst. So you can see the after surgery, you can see the complete removal of the synovial cyst. The case is the unilateral approaches, bilateral discectomy. So this patient received the fusion surgery 2 times, about 10 years ago and 1 year ago. However, his leg pain occurred again. So you can see the bilateral down migrated disc herniations. Also, you can see the bilateral disc herniations here. So also you can see the severe stenosis. What is your opinion? This patient refused the fusion extension surgery. So this patient received the fusion surgery 2 times. I do not want to fusion surgery again. So by decision, also you can see the bilateral disc herniations as well as the stenosis. So my decision is unilateral approaches, bilateral discectomy, left side approach. You can see the L2 lamina. This approach is very familiar approach for the biportal endoscopic surgeon or the PSLD surgeon. So now I did ipsilateral laminatomy, and now I dissect the exposure of the lower lamina upper portion. Firstly, I did hypertrophied ligament flavum firstly, and now I did sublaminar bony decompressions using the diamond drill. And you can see the contralateral detach of the contralateral ligament flavum. This approach is very familiar surgical procedure. Now I did the contralateral central canal decompressions. So dissections between the adjacent tissue and the dura. Now you can see the contralateral traversing over to here. And now I did complete decompression of the central canal as well as lateral recess. Okay, and you can see the ipsilateral. Now I remove of the down migrated disc herniation firstly, left side. Also, this procedure is a very familiar approach for the biportal endoscopic surgeon. So down migrated disc herniation is complete removal. Yes, you can see the ipsilateral traversing of the two here. And now I move to the contralateral sublaminar approaches. Also, I remove all the contralateral disc herniations using ipsilateral approaches. Now I move to the sublaminar and yes, and complete removal of the contralateral disc herniations here. Also, I check the axilla portions. Yes, also remove of the axilla. And now I did the annuloplasty using the radiofrequency, ipsilateral, and decompressions, contralateral, and central canal. The final view, and finally I put in the epidural, the drainage catheter after contralateral, central canal, ipsilateral, neural decompression using the unilateral approaches, bilateral discectomy. After surgery, you can see the central canal decompression and the bilateral disc herniations were completely resolved only unilateral approaches. So ASD decompression or ASD discectomy is another option of the biportal endoscopic surgery, especially sublaminar contralateral approaches. So, however, the extraforaminal area, there are the limitation of the contralateral approach. So, based on the middle portion of the pedicle, the outside of the area, if the pathologic lesion located, the paraspinal or transforaminal approach is better than the contralateral approaches. So, in summary, so optimal indications of the contralateral sublaminar approach, uniportal or biportal. The upper lumbar migrated disc, foraminal disc herniations, foraminal stenosis, cystic lesion. To combine the lesion also very useful approach. So we can well visualization and we can complete the decompression, extended root as well as traversing of root. So these are my articles about the sublaminar contralateral approach using the biportal endoscopy. Thank you for invitation. Yeah, thank you.